Hey everyone, welcome to the Nursing Insights podcast. My name is Stephanie and I'm a registered nurse practicing in the state of New Jersey. Getting right to it, the state of healthcare right now is tough, to say the least. Let's just say that the nursing shortage does not spark joy. We can sit in that and stew in it for a while, but we can't live in it forever. Things are changing. So join me as your host as I partner with the New Jersey Collaborating Center for Nursing to hear from nurses across the state about their experiences, trials, and triumphs in the nursing profession. For this episode today, I have the honor of speaking with Anne Alonzo, the Director of Nursing at Christian Health in Wyckoff. Anne, thank you so much for joining us on the podcast. Could you tell us a little bit about your role?
So I am the Director of Nursing. I oversee our long-term care and subacute rehab. So it's 298 beds. I am responsible for the overall care and accountable for all the clinical nursing care in our long-term and subacute, and also overseeing the nurses and the nurses' aide providing care.
That's an insane amount of responsibility. That's amazing. Could you tell us a little bit about your nursing career and how it is that you ended up in long-term care?
So I came from the Philippines. I had my bachelor in 2007. So I came here. When I first started here, I didn't know that there's different setting because, back home, it's just the hospital and home. And I got to learn different settings here. So my first experience, I was in a subacute rehab and usually is attached to a long-term care. And, I started in California and then I came here in New Jersey. And that's where I started my nursing career. I also had the pleasure to work in an assisted living throughout my career, but I'm always very attached to this setting, which is long-term care. I also had a background on a facility that specializing psychiatric illness or dementia with behavior. So that is still part of the long-term care. So that is my journey here.
Oh, so let's dig into that a little bit. So you started off in subacute as a floor nurse?
Yes. I started off as a floor nurse, and then I was trained as a charge nurse. I also was trained to be an MDS coordinator. What an MDS coordinator in a long-term care and subacute, there are nurses who does assessments. They're responsible for the reimbursement of the services that we provided to the patients. So it's really a good skill to learn. And that's the beauty of long-term care, by the way, is you have a different career paths. You could be an educator, you could be MDS, you could be employee health, you could be charge nurse, or you want to remain at bedside, as well as being an assistant director of nursing and then eventually a director of nursing. Floor nurse, charge nurse, MDS coordinator, and then assistant director of nursing, and then director of quality and regulatory services, and now I'm a director of nursing.
What an amazing array of experiences you've had in order to prepare you for the director of nursing role. Could you tell us a little bit about how, pieces or elements of each of those experiences in your career have helped prepare you to be a director of nursing?
I always look back in my 12 years in this setting and say that you really were trained to be where you are right now. So for the young nurses, embrace where you are right now, because you're learning and you're being trained to be at some place one day. And as a floor nurse, of course, you learn the basics, right? The basics of providing care. You're learning, how to build that relationship with your patient, know the responsibilities of your team. When I say team, your CNA, what's the role of the social worker, the dietitian, the interdisciplinary team. You get to work with them closely on the floor, as well as the physician and any other providers that is responsible for the care of the patient. And as a director of nursing, of course, I appreciate that I was a floor nurse, because there are things that, regulation change, and there are things that you need to improve or change, meaning policy and procedure or protocol, and knowing what's doable and realistic on the floor helps. I can't just say, oh, regulation change, I need to change the process. Tomorrow, this is what we're going to do. You can't just delegate and change or ask people to do things when you don't know really if it's realistic or not. So that's the advantage of starting as a floor nurse. you appreciate the responsibility and the roles on a daily basis.
And another experience you had mentioned in there was being in quality. Do you see that a lot of the work in quality that you did also affects the way that you practice as a director of nursing?
Absolutely. Quality is everybody's responsibility. You don't need a title, right? You don't need a title to enforce or to make sure that we're providing quality care. So I always say that everybody's responsible of maintaining quality. So if you're a floor nurse, a charge nurse, and you think that this process, it could be improved, then you talk to your charge nurse or your, director of nursing, and you put your input and to improve quality. To your question, yes, because you get versed to the regulation and the guidelines of the Department of Health, of CDC, of CMS. So yes, when you're solely just quality, you get to I'm not saying memorize the rules and regulation, but you're on it all the time. What I always say to the assistant director of nursing and the charge nurses, just having the regulation as guidance, we could always improve our quality and look at our process. So that's mainly my job, is to look at what the policy and procedure right now, what are the processes in place, what are the systems in place, and do they coincide with each other, or do we follow the guidelines and the regulations properly? And then you look at the floor, is the workflow realistic to meet the regulation? From there, you make your changes. But then having that background of what's realistic or not, because I used to be a floor nurse, I used to be a charge nurse, so it helps.
Yeah, that makes perfect sense that you would combine both the clinical capacity and the clinical skills that you develop with this strategic thinking, this systems-based thinking, the systems improvement thinking that you have in quality in order to lead an organization through the nursing workforce. So that's
Right.
super cool. Could you tell us then a little bit about what a day in the life of a director of nursing is like?
Okay, so the three things I want to know when I first come in, of course, I check. First thing I check, the census, the current patients that I have, the staffing. You want to know who you have right now. Staffing and patients. And then I go to the 24-hour report, the highlights of the day, past 24 hours. It kind of like your driver for the day. People who had a fall in the past 24 hours or monitoring for acute illness, anybody that had any kind of incident or any acute change of condition. Those are the people that you want to be focusing on. The new admissions, and then you go start doing your chart audits, meaning, again, that's still your driver. You want to continue doing chart audit on why did Stephanie had a fall yesterday? You do your root cause analysis, why Stephanie had a fall or why this person went out to the hospital. So those are the main focus that I have when I first come in. And then in between, of course, there's meetings about staffing, meetings about your inventories, meetings about infection control. So in between, there's a lot of communication with other departments. So, and I represent nursing for that. And then, of course, after those meetings, go back to the floor because you also have to relay and update the line staff after meetings.
So you actually spend quite a lot of time engaged with patients and with your nursing workforce.
Yes.
It's a very hands-on.
That I have to keep because that's just my style. I'm not an office type of director of nursing, but sometimes you have to lock yourself when you're trying to finish a report or a deadline, but most of the time out and about.
What an amazing philosophy to be out and really getting a true pulse for yourself of what your community within the organization, within the healthcare facility is feeling, what's happening. So I think that's just such a great dimension of leadership that you're displaying because it makes such a difference. At least for me, being a floor nurse, knowing that I see my director of nursing around, knowing that I can approach her if I feel like there's concerns. I really hope for all the nurses out there listening that that's the kind of support we can have. That's just a beautiful approach.
Yeah, I think that's the biggest foundation that any nurse leader should have is the relationship with your line staff. That is one big foundation that you want to build and you want to maintain. And then as a leader, you look ahead. Who's going to be next? Who's going to be the next charge nurse? Who's going to be the next supervisor? Who's going to be the next me, right? You want to be that transformational leader that you're preparing. I feel like long-term care at some point is invisible. And this is a very important part of care continuum, for the patient. So training and mentoring the new force, the new workforce to lead one day is very important.
You just brought up so many amazing points in there. I have a bunch of questions to follow up with that. One of which being you're talking about how it's so important for leadership to be visible, for leadership to reach out and to help develop the next generation. Was that an experience? Did you have any leaders in your life that came after you and said, hey, I could really see you, Anne, as being a leader? Or was that something that you kind of paved a way for yourself for?
I've met a leader like that, but throughout my career, I've learned that most organization or it's not even like just healthcare. It's that we're very dependent on like one position or one person being in that position when like the pandemic happened. So when things happen, when there's a disruption on and you're just dependent on one charge nurse and something happened to that person and nobody else could function, like the flow gets disrupted when you don't have a backup or train people to do a certain task. I just believe that everybody should be open on mentoring and training more individual to be able to function different position, not just be fixated. I'm a bedside nurse. I'm only going to do this, because you'll never know that, oh, I have the capacity to be a charge nurse until you try it. So it's so good to have a succession plan. I work closely with the educator, so we will have team leader, a charge nurse training. We will have supervision training, because if something happens, it's good to have, people that also know the job and the role, and not to just be dependent on one person. And I think education, improving their skill set, empowers the nurses, right? You just continue to learn, enhance your skill set, and have that conversation that I think you really have that leadership skill that we could mold you to be a supervisor one day. And if they don't try it, they wouldn't know. And I'm just lucky that most of the people that I approach and try to mentor, they tried it. And I am very fulfilling, and you feel proud. One time you have a clerk that used to be, now she's a nurse, and sometimes she does supervision. Sometimes she's the infection control nurse. Like, it's just amazing
to be a part of somebody's journey like that, to see them grow.
Be a part of somebody's growth, definitely.
And what would you say if maybe you have a young nurse or a new nurse who is still hesitating in accepting a little bit more responsibility, or still uncertain? Maybe they don't feel like they have the clinical skills built yet, or maybe they're just hesitant to take up more of a new responsibility. Do you have any advice for them or any thoughts for them?
Don't say no. When you say no, that's an opportunity of growth that you're already turning down without even trying. You gotta, and I get it. It's intimidating to be in a role that is responsible for just the patient, because as a charge nurse, you're also responsible of your other team members. But it's part of your growth, and you just have to look at it in a positive way. That, do I really want to be a bedside nurse or do this for this amount of years? Like, you have to sometimes sit down and be like, what's my goal? This is my purpose right now, but what's really my goal?
And I just think it's so powerful the way that you had said that, because I mean, here you are, you're a very seasoned nurse, you're a director of nursing, and you can still acknowledge that growth opportunities can be scary. Like, it can be intimidating to take up a new opportunity, but everyone from a new floor nurse up to the director of nursing can say, hey, this is an opportunity, and it might be intimidating, but it's something you should give it a shot. So that is so heartwarming for hearing it as a nurse who's, for me, in like the middle of my career and still learning. It's so wonderful to hear that, yeah, things will continue to be intimidating, but it doesn't mean that you should let yourself get in your own way. You should say yes, give it a shot.
Right. And healthcare system, it evolves very frequently than it should, the evolution of it. And you just have to go with it and learn the new things. I feel like every quarter there's a new guidelines, there's a new regulation that you have to relook at what you have and continue learning. You continue networking so that you could see and have an idea of how do they do this? How do they do things in other places and other facilities? And you build relationship with other people too.
Yes, that's a beautiful direction. So shifting gears a little bit, you had mentioned before, kind of similar to this, that the long-term care kind of time in the patient experience can sometimes be overlooked. It can sometimes, like, I think the word you said was invisible. And going out and networking and becoming involved in the community and understanding the specialty that is long-term care can really make a difference, I think, for nurses starting out, even if they're not in long-term care yet, just understanding where the patient is going and what happens in long-term care settings that's different from acute care settings or home care settings. For some of our nurses who may not be familiar with long-term care settings, could you tell a little bit about what makes long-term care different from those other settings?
Absolutely. So, well, one, you build a relationship, you get to know more about the patient. And when they come here, remember, it's not just helping them physically. They're going through a lot mentally, emotionally with the adjustment. And that goes to subacute rehab as well. You're not in your prior level of functioning. In this setting, as a nurse, critical thinking is very important. It's not just giving them their medications. We're getting patients that has acuities, new Foleys, new tube feeding, new disease or illness that they never had before, or a decline in function. So as a nurse, you're not just, let me give you your medication or do your treatment. It's more of also, how do I get this patient back to where she, or at least close to where she used to be? Because it's not just that healing, it's mentally and emotionally, they need healing too, right? And not that just them. In a long-term care, it's not just them, it's the family too.
What a beautiful differentiator. And it's true, the focus in acute care is often just treatment. What is the acute problem and how do we stabilize? How do we treat? How do we get them out of the danger zone? But with long-term care, it's how can we bring them back into their daily life? From a place of acute trauma, acute disappointment, acute, there's so many feelings that come along with, being vulnerable and being in the hospital and being scared, and transitioning them back from that point into their daily life with potential new, like you said, Foleys and potential new treatments that are something they've never had to consider before. So there's a lot more that you're looking at in a patient in terms of not just their treatment right now, but how can we best transition them back?
Absolutely.
Would you be also using a lot of the same or working with a lot of the same allied professionals? Would you still be working with a lot of the same dietitians or some of the same speech and language pathologists? Which kinds of professions would you be working alongside?
So part of your interdisciplinary team here, you said it, dietitian, you have every doctor who's following the patient, you have the therapy, physical, occupational, speech, social workers. So there's a lot of communication with the interdisciplinary team and the family, and setting up goals for the patient. So that itself is already fulfilling for a nurse to be like, I'm going to get her home, or if not, I'm going to feel home here with us, providing the care that they need and maintaining the quality of life. And subacute, yes, you set goal. We try to work with them so they could be at least close to prior level of functioning or their prior level of functioning. In long-term care, we want to maintain the quality of life. And how is that being achieved? Is that maintaining activities, interaction with other patients, the staff, and of course, maintaining the highest level of functioning for their activities of daily living. So that is our main goal for the patients that are in long-term care, maintaining the quality of life and making sure, they're not going to decline functionally.
Thanks for listening, everyone. We'll see you next time on the Nursing Insights podcast.
This podcast is brought to you by the New Jersey Collaborating Center for Nursing and the Rutgers School of Communication and Information.